We've all got the same 24 hours in a day. What you do with it is up to you, and the supplement you take can help you make every hour count. For the maintenance of good health, choose DS24. DS24 provides the perfect balance of vitamins, minerals, antioxidants, and essential fatty acids to make every day your best day. Your life demands DS. DS24 multivitamin and mineral daily supplement. Find the full DS range at all good pharmacies.
Good morning, everyone, and welcome at the Pelvic and Women's Health in Sport Interest Group. It's one of our first meetings of the year, and we are addressing a very interesting topic this evening. We actually chose it because there has been so many questions around it. And when you start delving into this topic, it becomes actually quite interesting, as I think you will see during tonight's presentations as well. So tonight, the first presentation will be by Dr. Marlena du Toit. She is a gynaecologist who completed a medical training in 1998 at Stellenbosch University. She worked a while in rural South Africa and also in the UK. And then she qualified as an obstetrician and gynaecologist in 2008 at Stellenbosch University. She has been in private practice since 2009, and she recently also pursued her interest in sexual medicine. She is the program director of positive sexology at Stellenbosch University, and she is also the chair of the Sasha Western Cape branch. During her career, she co-authored 2 books as well, Antenatal Care Journal, as well as a book on pregnancy loss, which is called Leeg, and it was awarded with an award with Cordis Trust Prize in 2018. She enjoys public speaking about sexual medicine across the Western Cape and Northern Cape, and actually across South Africa. And hiking in the Western Cape is one of her favorite activities. So welcome, Alina, and thank you so much for availing yourself to do the presentation tonight. We are looking forward to listening to you.
So yeah, thank you for the opportunity to share some of the things that I've gathered in the last couple of days when I started reading with this in mind, thinking of the female athlete and not just as a normal woman sitting in front of me. And for me, understanding the menstrual cycle has, since I was an undergrad student, always be like a fascinating thing. What on earth is going on in women when it comes to hormones? So let's see if I can share some knowledge that I've gathered over the years with you. It's interesting to think that every month the womb and the ovaries has got one goal, and that is there's the possibility that a woman can become pregnant. Every single month, that's the aim of the game going on, what is going on in the uterus. It is actually very interesting to note that menstruation is not just blood. It's much more than just blood. It's an inflammatory process that's going on every month in a woman's body. The menstrual lining that forms is nothing else but inflammation. And if I say it's inflammation, what I mean is there is red blood cells and white blood cells, there's mucus cells, but there's also proteins and cytokinins and metalloproteins and quite a lot of things that is interesting and that we can work with when we want to manipulate the menstrual cycle a little bit. I'm talking tonight about the natural cycle. So this is how hormones are fluctuating, and it's quite unique. We're not talking about or referring to a manipulated cycle. So that's when someone is in contraception. I'm going to speak to you about the natural cycle as it is on its own. So menstruation is the process that happens. The menstrual cycle consists of different phases. The menstruation, the actual shedding of the material through the vagina. And after that, immediately, it's followed by follicular maturation in the ovary, ovulation that happens in the ovary. And at the same time, the menstrual lining starts to rebuild. And then after ovulation, we get the corpus luteum formation. And once there's shedding again, it all repeats from the beginning. And every month this happens. So you can see there's actually 2 processes happening at the same time. There's subphases, and we'll look into that once in a short while. The typical age of a menarche is around about 13 years, and women will keep on having a natural cycle every month until she reaches the phase of a perimenopause, which usually is from 47 years onwards. So if you look at this this picture, I want you to look at the top row at the ovarian cycle. So every month in the ovaries, there's a lot of follicles that plays a role. And then the last line, the uterine cycle, is actually in the uterus, what happens there. So these two processes that happens is controlled or under the influence of 4 hormones, basically. And that is estradiol and progesterone that comes from the ovary, and your follicle stimulating hormone and your luteinizing hormone that comes from the brain. I don't want to be too technical, but this, if you understand this, women usually get a lot of understanding of what's going on in their bodies. So, like I said, in the uterus, it's like the field. It's good that I always think of a menstrual cycle as a sports game, usually a team sports, not necessarily athletics, but a team sports like netball or hockey or soccer or rugby. You know, there's a field that the playing happens on, and there's the players, and I usually think of the ovaries with its follicles as the players of the game. And like any sports game, it has a typical time. Now, a typical time for menstrual cycle is 28 days. And like a sports game, there's a halftime, a break. And that's usually day 14 when we have ovulation, when things change. So in the first half, usually the follicular phase, there's a dominant hormone, and that's estradiol. In the second half, in the luteal phase, the dominant hormone is progesterone. So in the first half, under the influence of estradiol, after the menstrual shedding has happened, so the uterus is kind of clean now, it starts to build up the menstrual cycle, the playing field once again. And then that is what happens in the uterus, and at the same time in the ovaries, 35 follicles usually on average recruit to be that month's team. And the aim of what they have in mind, the game plan for the first half of the cycle, is to form a Gravian follicle. And the Gravian follicle is that big follicle that contains the egg that's going to ovulate and on day 14. Now, this is in a lady who has got a 28-day cycle. Now, after ovulation, that same Gravian follicle in the ovary continues, but it changed its name. The Gravian follicle now becomes the corpus luteum, and where the dominant hormone, the captain of the first half, was estradiol or estrogen, the dominant hormone in the second half is progesterone. And under the influence of progesterone that comes from your corpus luteum, the endometrial line starts to thicken, and it becomes rich and ready to conceive a pregnancy. All of this change over from estrogen, estradiol to progesterone, and ovulation happens under the regulatory influences of the LH and the FSH hormones that comes from your brain, the hypophysis and hypothalamus. So this is basically what happens every single month in a woman's body. So we have these different phases, and you, after the menstruation, your follicular phase, you can divide it into a mid follicular phase, early, a mid, and a late, and your luteal phase once again in an early, a mid, and a late luteal phase. But most important is that we have in the first half a rise in your estradiol, the estrogen part, and after ovulation, it doesn't completely disappear. It just becomes less prominent, and progesterone is very low during the first half, but it becomes very prominent in the second half of the cycle. And this is something that we're going to have a look at. There's just a little bit of a simpler explanation of how LH and FSH peaks just before ovulation to control the changeover from estradiol to progesterone release, and the peak leads to ovulation, and then your corpus luteum continue. So this is in a woman with a 28-day cycle. There's a lot of variation in cycles of women that's normal, and it can be from 25 to 35, we would say is still a normal cycle. The moment it becomes longer, we are aware that there is some abnormalities in the menstrual cycle. So it's typically it's a 28-day cycle, but there can be a lot of variation, and you can imagine if all of this is squashed into 25 days, the impact is going to be much more present in a woman's body than someone who's having maybe a longer cycle. So if we look at different hormones, estrogen in the first half affects primarily, or not primarily, but it affects many of the organs in the body. We know that it has an impact on memory and your controlling, your regulating your body core temperature. It has an effect on libido. In the heart, it protects the heart against the effects of cholesterol. In the liver, it regulates the production of cholesterol. It's so important to know that estrogen plays an enormous role in strength of one's bones, and it also increases bone density. It is one of the best cures or things to keep in mind when we think of anti-aging aspects of no one wants to become old, too early in life, but it really plays a big role in your skin in terms of preventing or just managing the anti-aging aspects. In our breasts, it's responsible for growth and, of course, for breastfeeding. And then, like I said, it has a big impact on controlling fertility. But from a sports point of view, it is really interesting to see that estrogen has a neuroexcitatory effect on production, force production. So that is muscle strength and power. That to me was quite a interesting thing to find. Progesterone, on the other hand, if we just look in general, it also has an effect on breasts. It leads to swelling and tenderness in your gut. It causes bloating and weight gain, water retention in the brain. Anxiety, agitation, depression is associated with high levels of progesterone and of course fatigue. When it comes to one's neurological system, the progesterone inhibits cortical excitability. So all the neurons and the synapses, the complex cellular network where they are involved, and we need our neurons and synapses to work quite controlled when it comes to movements, thinking, emotions. It impacts so many things. But progesterone actually inhibits the cortical excitability. So that was also interesting to know why, or what it is doing in our bodies. This slide wants to demonstrate to you that we have all these hormones present, as well as testosterone. I think that to me was the other thing that I realized, that for so many years, we as women has been, we've used whatever has been published in research and in science in men, we've extrapolated that to women, and we haven't really paid a lot of attention to the interesting hormonal world that exists in a woman when it comes to her cycle. And whatever we know about sport, we've extrapolated, and we cannot compare men with the extreme doses of testosterone with women. And I'll show you now the difference between the two. I mean, everyone is aware of it, but I'll just show you. So this slide just shows you estrogen. It is there pretty much from the beginning of one's life. Your ovaries, when a little baby girl is born, she's got all her follicles packed into her ovaries, and they go to sleep until puberty, when she starts to have a menstrual cycle. In the beginning, it can be a little bit irregular, but as she ages and goes through adolescence, it becomes more regular. And then throughout the 20s, it's fairly stable. And from 35, we start to see a slow decrease, and that continues until we reach menopause. And then there's quite a up, down variability that happens with estrogen around about 50, 52, 53. And then after that, there's a complete decrease. Progesterone pretty much follows the same path, but there isn't so much fluctuation when it comes closer to the menopause period, and testosterone over time just completely slowly declines. It's never a big role player. What's interesting is that the menstrual cycle affects one's mental health, and if you just look at the menstrual cycle, in the follicular phase, where estrogen is your dominant hormone, there is after the menstruation has actually happened, when the new endometrial lining starts to form, you do see that there's an increase in energy, self-esteem is good. If women really feel sociable round about ovulation, it's well known that if a woman is not on any contraceptive, there's a libido increase in a libido. And usually as the cycle progresses into the luteal phase, she's more calm, but she's also towards the end more vulnerable. And fatigue is quite a common phenomenon towards the end of the cycle in many women. And then if you just look what the menstruation cycle is doing to your gut, estrogen actually increases peristalsis, and that can lead to diarrhea. But it also increases the microbiome's diversity, which can actually improve your immune system. And then if you think of progesterone, the second half slows down your peristalsis. So women often find that they're constipated in the second half of their cycle. And it unfortunately can also relax the stomach's sphincter, so that could lead to reflux and heartburn. If one look at testosterone, the normal range for testosterone in women and in men is just, you cannot compare it. The male levels is between 270 to 1,070 nanograms per deciliter, where we as women has got the lowest, imaginable levels of 15 to 70 nanograms per deciliter. So it's really very low. Testosterone does not play a big role in a pre-menopausal woman, and we cannot rely on the presence of testosterone in our bodies. We cannot, like men, make use of it, because there is just not the same kind of levels. This is just to show you that even during pregnancy, in the first, from the first to the third trimester, females do have testosterone, but very little, and male babies do have a lot more. And throughout our life, we are always on the lower side of this curve, where men in their 20s to up to their 60s has high levels of testosterone. And then if you just look at this one, it's once again the cycle, instead of days, it's just in weeks. So there is a slight raise in the normal deviation from the normal low amount of testosterone around about day 14, the day of ovulation, when it comes to testosterone. So it is as if testosterone just quickly peak a little before progesterone takes over and dominate the second half of a woman's cycle. So yeah, once again, testosterone for women don't help us a lot when it comes to sport. So let's just think, if a woman is having her period, she's going through this increased inflammation process, and that's usually not a very nice feeling. That's why we get a lot of pain and cramps and bloating. It's the end phases of the progesterone coming to an end. The fatigue, cramping blends into the feeling and symptoms of inflammation, and that's why we often suggest that women take anti-inflammatories maybe just for the first day or so. Even if you suspect your period is coming, take it a day or earlier. With all the blood loss, there may be a little bit of a higher need for iron during the period of menstruation. And this actually, if your period symptoms are under control due to the low levels of estrogen and progesterone, it can actually be optimal time for peak performance. But it is important that you just are aware of your menstrual symptoms and that you manage them quite well. When we look at the follicular phase from day 16 to 14, that's where we still have in the beginning low estrogen and definitely low progesterone. But as the follicular stage continue, the estrogen starts to rise. And that's the time when your brain feels happy and you have good self-esteem. But actually, you have a perceived experience that your pain tolerance is better and you feel that there's more energy. Our muscles also have a better ability to utilize the glycogen as a source of energy, and we may feel more motivated and experience high moods. This is now a good time to concentrate on high intensity endurance and strength training, and this is what they say, this might be the optimal time for peak performance. And then we get ovulation somewhere between day 14 and 16. This is where there's the surge in estrogen. There can be a little bit of a decreased stiffness in tendons and muscles. You may actually feel quite mobile, and mobility may be better, but there's increased risk. This is quite interesting as well, that one must be aware there's increased risk of muscle and tendon injuries, and especially your ACLs during this time of ovulation. Coming to the second half, day 16 to 18, this is where progesterone is dominant and the estrogen is lower on the radar. PMS may start interfere with training and performance. Closer to the end of the luteal phase, your body can start to have water retention. Now, the thing here is that not a single woman is the same. There's such a lot of variation in how long the luteal phase lasts. The fixed part of every single cycle is the first half, or actually the second half of, let me just start over again. The fixed part of a cycle is from ovulation to menstruation. So it's always around about 14 days from ovulation to menstruation. So that's the fixed half. The first half can be variable in all women. So when ovulation takes place, that is the thing that we don't know. But we know that once you have ovulated, usually 14 days later, you will get your period. And it's just what happens in the second half is that we don't know, or in all women, it's quite unique. When would PMS kicks in? When would that progesterone reach such a high level that it starts to influence your body to feel PMS? Some women starts to have it from day 17 onwards. So they do have a very long a period where the luteal phase influence them quite severely. Your stored carbohydrates that's usually very much available becomes unavailable, and that leads to an increased appetite. That's why we have these cravings. There also may be a decrease in muscle building capacity. And you could find that performing in heat or humidity can be more difficult due to the increase in elevated core temperature and the plasma blood loss that you experience with the menstruation that's coming. So this is not always the favorite part to participate in activities. So in the luteal phase, it's really important that you take it easy and that you focus more on relaxation and not high intensity exercises. So what the hypothesis is that the best time of the months to perform, if you can, should be when there's low progesterone and elevated estrogen, and that will usually be in the mid to the late follicular phase of the first half, and that's when we think is the best time for one's optimal performance. But always, if you know these things and you can preempt it, I mean, if you can change your mindset, women are able to mitigate these symptoms. And it is possible to participate during the luteal phase and still have a good performance. Same with your menstruation period. If one manage your symptoms with the help of supplements like omega-6, evening primrose oil, vitamin B6, magnesium, zinc, and vitamin E, that really helps a lot, apart from anti-inflammatories, to ease the symptoms that happens in the second half, the luteal phase of one cycle. Now I want to touch on amenorrhea, that is the absence of one's menstrual period. And the question is it your friend or is it a foe? There's this phenomenon of a female athlete triad. And this is a spectrum of conditions that includes low calorie intake, missed periods, and loss of bone density. That's the triad that they are talking about. And it's estimated that 25% of elite female athletes report chronically missing their periods. And it's specifically noticed in women doing ballet and female athletes. So low calorie intake, missed periods, and low bone density. And exercise it doesn't even have to be extreme. There must just be an energy imbalance and not enough calories to support the demand of the exercise, and that can lead to the female triad that we see. So if you look at the green triangle, eumenorrhea, that is where you have a normal regular cycle. That can only happen if there's optimal energy that's available, good, healthy, balanced diet, and that leads to optimal bone health. And if that changes, if there's a reduction in the available energy, or if a woman has an eating disorder, it can lead to low bone density, and menstrual patterns can change. And the problem that we see in 25% of female athletes is that they become amenorrheic. So there's a shutdown from the body side, where the brain just decides that survival is more important than being fertile and having producing babies, or the ability to produce babies. So it shuts down the fertility, the whole menstrual cycle, and it preserves the body, just your important, most essential functions. And that's when there's an eating disorder, or just not enough energy available. And then what happens secondary to that is that we get that has an impact on bone density, and it can lead to osteoporosis. So this is when this happens, when someone over a period of time is chronically missing her periods. Now remember, there's this woman who's not taking any form of contraception, hormonal hormone replacement in the form of contraception. So it is really important to know that the long-term health consequences of the triad is really dire. And like I said, it doesn't even have to be extreme exercise. It's the balance between exercise and calorie intake where this mismatch starts to happen. So we know that there's the risk of osteoporosis, bone fractures, heart attacks even. Of course, fertility comes in, and vaginal and breast atrophy is something that we see. And women with amenorrhea often have as a decreased bone density, and they face this risk of osteoporosis. And that's not something that we as young women are necessarily aware of. We always think of osteoporosis as a disease of someone in their 70s, and not women that's still in the fertile period of their life. But you can lose about 2 to 3% of bone mass per year if it's left untreated. So that's quite important to remember, that it's very convenient not to have a period, especially if you're an athlete, but it's not the healthiest thing for your body to go through in the long run. And this is also quite interesting. We often hear of our friends participating that they have a stress fracture, or there's some kind of bone injury. That is actually a sign that there can be decreased bone strength and bone density, and that they are at risk of developing osteoporosis. So yeah, cardiovascular complications. Remember, estrogen protects the heart against the effects of cholesterol, and it helps with the production of cholesterol in the liver. So if there's a decrease, as with amenorrhea, there is more cholesterol issues and heart attacks later on in life. It becomes very obvious, or it becomes very real. We often see so many sports stars just having a sudden death, and especially when they are maybe in the middle phases of their life, and we often say, but he's so healthy, or she's so healthy, and we don't understand it. But many of the decisions that we make regarding our health do have an impact far more than what we usually perceive. So it is really important that we should treat the triad that can prevent potentially life-threatening illnesses. And it's not that difficult. One must just encourage women to increase their energy intake and reduce training with something as little as one less training day per week, until their period starts to come back. And usually you see the improvement in their periods fairly quickly when they just reduce their training with 1 day. And then we know their bone health and their cardiac health will not be affected on the long run. And sometimes athletes are very concerned and focused on what she's eating, but sometimes that energy is just not enough to support the exercise routine. And sometimes it's as simple as adding an egg or a spoonful of peanut butter to a meal, or changing from skim the milk to full cream milk and yogurt. So yeah, there's a lot of variability, and it's so important that you track your cycle if you're not on the pill, and that there should be good communication between you and your coach, and call in your GP or your gynecologist if you experience problems. As important as exercise is to us, and exercise is, in my opinion, really so important these days, especially where we are all living after a high-paced life, after 3 years of being in a pandemic, and we've lost so much of our resilience due to sport activities, and getting together and just going outside has been taken away from us. I do think it's important that we exercise, but we must do it without doing harm to our bodies. And then there's always life little hacks, your mental health can play a role. You can be on medication, and that can influence your cycle. Some women has a family history of hypothyroidism that could be influencing your cycle. So it's not just always exercise, but you have to take all of that into consideration. Chronic conditions, maybe diabetes or asthma, can play a role, and that can influence your ability to exercise. There could be an injury, you could be on medication. And interesting enough, I'm not so clued up about the figures in the rest of South Africa, but I know about 2/3 of women in the Western Cape suffers from an iron deficiency. And it's always fascinating when you talk to women about their cycles and how much do they actually lose during the period. And women just accept that as they grow older, it's okay to bleed more. They think that's the natural cause of a cycle, and it isn't. You shouldn't necessarily lose more blood and change your sanitary wear to cover the loss, or manage the loss that the menstrual flow that you experience. But we don't compare notes on that, and sometimes women just accept it. It's like a culture of silence. We don't talk about how much blood you lose per menstruation, but it is important to go and check yourself for iron deficiency, and it's necessary to do more than just the finger prick hemoglobin test. So important. You need to have a look at your iron stores. Iron stores is in the bone marrow, where they produce the iron, and we measure it by looking at ferritin levels in your blood. And ferritin for women should be, the cutoff point is 30. If it's below 30, we say she's got an iron deficiency. But even 30 is the lowest of normal. We know that women perform much better if their iron levels is at a level of 100 units. So it is really important to once a year just check what's your iron status, because we need the iron, the ferritin levels to be high, because we use ferritin to produce hemoglobin in our bodies, and hemoglobin is the substance in your body that carries oxygen. So very often people would say, yeah, but I do donate blood, and I can still do that, so they do my finger prick and that's fine. But it's far more important to look at ferritin levels, what's going on, because otherwise, if your ferritin levels is completed, you will not have enough to continue to maintain a stable hemoglobin level. So that's just a little bit of a caring thought from a gynecologist. So there's many things that can influence our cycle, and we should just keep that in mind as well. Just a short word on contraception. There's so many options available these days. The oral pill is available. It's really a low dose of estrogen, progesterone. It shuts down the ovaries completely. So your own hormones goes to sleep. Within 3 cycles that you've taken the oral pill, your own hormones, your own ovaries don't produce estrogen, progesterone anymore, and your body rely on the exogenous estrogen that you are and progesterone that you are giving to it. And the difference is that every single day when you take the pill, there's the same amount of estrogen, progesterone. There's no variation like there is in a natural cycle. With injectables, we know that what we have is mostly progesterone, and that just shuts down the menstrual cycle. There's no menstruation that forms. It's the way how it works on the body to prevent pregnancy. And long-term use of injectables, the Depo-Provera, the Noestrate, can actually lead to osteoporosis because she doesn't ovulate. And it is important that women don't stay for too long on injectable contraceptions. It's a good form of contraception, make no mistake, but one mustn't stay on it for too long. Otherwise, there's a risk of osteoporosis later on in life. The ring is quite convenient these days that you can insert into the vagina like a tampon. You can stay in for 3 weeks. You can tricycle by using a ring just continuously for 2 to 3 cycles, and then only menstruate every 3rd or 4th cycle. And the ring contains estrogen and progesterone, so it's not something you have to drink every single day, which we as women like. IUDs like a copper T or the intrauterine system like a Mirena. That is also methods that's available. And then, of course, there's permanent methods, and then you'll have a natural cycle once again if you've had a sterilization. That's just so yeah. And if you would ask me what I think, I think it is good to have for athlete. I think it's good not to have menstruation, but I do think it's good to have your hormones free, your ovaries free, and rely on your own ovaries to provide you with hormones. And if possible, I would advise an athlete to use the intrauterine system like the Mirena, or that within 6 months it binds to all the receptors in the uterus and you become amenorrheic, but your ovaries doesn't shut down like it would if you are in that triad that I explained. So you will be able to go through your own ovarian cycle every month. Your estrogen will rise, it will peak at the time of ovulation, and then it will decrease, and progesterone will pick up, and there will be a blip of testosterone. That's all coming from your own ovaries, but your uterus is kind of blocked, or with the Mirena that secretes only progesterone, and that gives us the ability to perform well and feel like ourselves, because we do like that, but there's not the nuisance of having periods to deal with, or to manage when you are performing. Fertility, you know what, we as gynecologists need to be open with people, to women, and say the best time to conceive is 25. From 25 to 30 is the best time, and that's a reality check that we as women don't like. We need to be frank. The media is going bonkers with everyone that's having babies late in their 40s, 50s, and even older. That is not the truth. The best time to have babies is around about 25. No, that is just not practical. So there is a movement to start to talk about egg freezing. Now, there's a lot of cost involved. Usually it's a once-off. If you're 25 and you do it, you freeze your eggs, it's a once-off a thing to do. You don't have to go a few times, but it is still a very new thought, but I do think it is important to remember your best years for having healthy pregnancies is from 25 and onwards. The perimenopause, that's around about from anything from 40, 45 up to when our periods stop. Usually 50, 52 is when the periods completely stop. I always say to women, don't be scared. I always believe the best is yet to come. Exercise is actually your best anti-aging tool, apart from the estrogen that you have. I usually advise all women to start, if you're not exercising diligently, do start before your 40s to come into a pattern of doing exercise. And if you are an athlete, whatever sport you do, try to keep on, respect your body, but try to keep on exercising throughout your whole life. Remember your sunscreen. We live in the southern hemisphere, and skin cancer is quite real. And of course, a healthy, balanced lifestyle where we give priority to all things makes the menopause not a nightmare. Once again, postmenopausal, once you're free of all the bleedings and monthly nuisance, it is important. Keep on exercising. Being on the other side of 50 doesn't mean that you have to sit and start doing knitting or something like that. You know, you can really keep on exercising. And I do think it's so important to work on balance and mobility. And if you are an athlete, try to bring some strength training or mobility exercises like Pilates or yoga into your routine to keep going. And we can have a long conversation about HRT, and I will not do it, but there's so many good products on the market these days that's really safe and that's very much natural, same, almost the same as your body, and it can really make life better. If you just think of it, that the shortest while of a woman's life is in her fertile years. We spend far more time after our menstrual, our fertility ceases, and we really need to embrace this period after 50 going forward, and we shouldn't be worried. We should keep on having a balanced and healthy and an active life. So yeah, often the question is, are we from Venus and men from Mars? It is just important that science, and I'm sure Corlia is going to touch on this, science should start giving more credit to female hormones and not just extrapolate from testosterone in men and how that influences a person's performance. And I really hope to see more of this. Our sports stars speaking up about their periods and the influence that it has on them, and that there will be more exercise. So yeah, where there's a woman, there's magic, and I really hope that this research inequality will end, and that women being athletes and sport, interested in sport and participating in sport will become a priority in research. Thank you very much.
Very interesting talk, and you definitely set the tone. So I'm not going to be long now because you luckily shared a lot of the information that I can just elaborate a little bit on. Right. So I love research. I always feel like you need to throw it in everywhere, and I'm specifically a supporter of translating evidence into practice. Just because of a couple of reasons. So first of all, if you go onto Google and you type in training and the menstrual cycle, I've only used one combination, not even more than one. You already get 721,000 results. So there's a lot of information out there, we think. A lot of advice that we can follow, we think. But how much of this is actually good advice, and how much of this can we follow and take as good advice? Let me just move this out of the way. Okay. So I think Marlena has definitely, emphasized what is the importance of looking after your menstrual cycle, especially as an athlete. It has so much effects on the musculoskeletal system, the systemic systems, the fertility. So a lot of health importance that a normal menstrual cycle has. So if we look at evidence, and I'm going to come back to the slide at the end, you have different types of research that we can do to determine different types of evidence or generate different types of evidence. So the first one is when we look at efficacy. So we look at what is when you have an intervention under controlled circumstances, what are the outcomes? So under ideal circumstances, meaning there's nothing like, weather and other previous injuries or anything that can influence the results. Then you have the research on effectiveness, or the pragmatic research, where we look at what happens if we do an intervention in a real life situation. You have other factors, influencing the outcomes. And then we also have implementation. research where we look at, you have now an effective intervention, but how can you adapt it to be really effective in a specific population, looking at contextual factors. For example, in South Africa versus a high-income country in Europe, it is going to be different. For example, and I think one of the questions was on that as well, we don't always have access for athletes or patients to the different type of contraception. So how is that going to affect how we apply the findings of what we would like to achieve? So I'm just quickly I'm gonna draw a little bit on what Marlena already went through regarding physiology, just to show, we have all this information and what's happening in the body and the theories we have, and what effect it can have on training and tissue and performance and behavior, and then end up with what is the evidence that we actually have on that. Okay, so I think first of all, Marlena, went through quite in detail on what is the cycle, and the important factor is, the length of the cycle is notoriously variable. But not only the length, there's so many factors that differ between women that becomes factors that you cannot ignore when you, start to adapt training programs or nutrition even. There's differences between all individuals. So what's important from what she presented is the estrogen, the progesterone, and then the two phases of the cycle, where it can have an effect on performance. So in the proliferative phase, the main hormone is the estrogen, which is in the first half of the cycle. And then during ovulation, it's still the estrogen, which has a different effect. And then during the second phase, the luteal phase, the main hormones is progesterone. And also to note here, you can look there at the bottom. So usually the body temperature increases during the luteal phase. And we'll come back to that when we look at the evidence again. So we know, these hormones causes different effects in the body that leads us to think, we can adapt training, or we should adapt training and nutrition, for example. And also important to note, what you also said, is the amount of blood loss is really variable between women as well. And that comes down to, for example, your iron levels. That can also have an effect on performance. Okay, so if we look at, what we find and what we know of the effects in the body, so estrogen, most likely, if we look at the effects on specifically our muscle tissue and tendons, it increases the collagen content of connective tissues, and it also improves muscle mass and strength. And that's where she referred to that, that increase in performance that you might experience, in the first half of the cycle. But at the same time, in tendons and ligaments, estrogen decreases the stiffness. And that can also directly affect the performance and injury rate. So it has a positive aspect, but it also has a negative aspect. And this is now, where the researchers started to think, okay, how can we now manipulate this to get just the good effects of the estrogen and not the bad effects? And we'll look at a study now that they've done. And another effect of high estrogen levels, it can decrease power performance, and it can make the woman more prone then for ligament injury. So there was a study that they've done. I just want to highlight a couple of things. So they looked, they looked at the young women who are not competing, but they also looked in competitive athletes. So in the young women who were not competing, the benefits of the high estrogen on the anabolic response, which we saw now in the muscles and the tendons, improve the muscle repair, means that over time, these women will have stronger muscles, tendons, and bone. As if they allow for this normal rise in estrogen that occurs before ovulation. While in competitive runners, we have a different scenario, and they describe it by actually contrasting them with those with having a female athlete triad. So if you have this chronic energy deficiency, it will stop the normal cycling and the estrogen levels will drop. And you can have the amenorrhea, the loss of bone mass, and also then the increased risk of musculoskeletal injury, as Marlena pointed out as well. So they suggest that competitive runners should look to maintain their adaptation to training, specifically during the off-season. I'm just going to go to the next slide. So if we look at adaptation of training then, so meaning, now they are trying to look at how can they adapt training to get the best effects of the different hormones and this fluctuating hormones throughout the cycle. Let's just first look at this, and then I'll come back to the problem that we have still. So this one study looked at that during the preparation phase of training, the athlete should consider contraceptive with the low levels of progesterone, because the low level of estrogen will then decrease the negative effect of the ovulatory phase, the rise that you have in estrogen there on the tendons and the ligament mechanics that we saw just now. It can have a negative effect on that. So training in the absence of oral contraceptives, a low tendon stiffness, but a higher anabolic response to training can maximize your muscle repair on hard days. So the outcome would be then a fewer muscle pulls, greater metabolic cost of training, and also an increased stimulus for adaptation. So the result would then be a high rate of force development, which will result in better performance and a low risk of injuries during the competitive season. The only problem with the research is that if you look at something like this, this suggested, how can I say, almost protocol or guideline, it would leave the athlete at a greater risk for injury, at least for 5 days a month during their training. So it's not the ideal strategy to follow. And also, we need other investigations, actually not strategies, first of all, investigations to look at how, if and how can the negative effects of the estrogen on the joint laxity be controlled for or manipulated, if you want to call it that. And then the aim of this is to try and to decrease the risk of injuries in women. Unfortunately, the studies that we have up to date have only, if they've looked at the effects of adaptation, for example, they've only looked at a certain phase in the menstrual cycle and not the whole menstrual cycle, which also makes it difficult to interpret because, as we see, there's a lot of variability between women and, lots of other factors as well, not only the hormones, but a lot of, contextual factors and also risk factors that can affect, of course, an injury or the amount of injuries that women sustain. So for the adaptation of training in postmenopausal women, okay, so the strategy is less clear, although it's still not really very clear in premenopausal phase as well, but it's even less clear postmenopausal. So the theory is hormone replacement can improve the muscle mass and the function by improving the muscle repair and response to exercise. It can improve bone mass and function, but long-term, hormone replacement therapy is associated with the decreased tendon cross-sectional area. So you can have maybe, positive effects in the short term, but long-term, again, you can have a bit of negative effects as well. So the problem that you sit then with is you have a bigger and a stronger muscle that's then pulling on a brittle tendon that is in turn connected to a stiffer bone, which will obviously make them more susceptible to injury, tendon injuries. And then on the other hand, you have, if you're not taking hormone replacement therapy, it could again accelerate, things like sarcopenia and osteoporosis. So there's pros and there's cons, and and as they also say, we need a way to get the positive effects of the hormones that we have in the normal cycle on muscle and bone repair, and also anabolic responses to the loading and the nutrition, but without the negative long-term effects that it can have on the tendon. So it's a complicated thing to investigate, I think, and it will require a lot of manipulation, which is also, I think you can reason, whether that would be a good thing or a bad thing. Just in short, the evidence So, when I started, I could say, what do we have? And the quick answer would be not much. But I prefer to go through about 20 slides before we got to that. So there's really not a lot of research on the menstrual cycle, the effects that it could have on women, and specifically performance. There's really a handful. And I've looked at the most recent. There's 1 or 2 reviews that, quite summarize it quite well. Meaning it takes into account all the evidence that we have actually up to date. So one review, it's actually a very recent one, that looked at, the navicular height in static standing position, and it was significantly decreased during the ovulation phase compared to follicular phase, and they also compared it to men. But it showed no statistical differences between the first and the second measurement. So in both men and women, the differences were identified for the dynamic medial longitudinal ligament arch kinematics, which was measured during the gait and landing. So we see differences during the first and the second phase. So again, there's lots of factors that could affect this. And, we need to sort out where and why these differences occur. Is it really just the hormones? Then there was a review that actually looked at thermoregulation. So if you think back earlier on, we said in the second phase, you actually have a change in body temperature. However, they compiled the results of a couple of studies where they looked at the internal temperature pre and post exercise during the different phases. And they found no significant differences in the skin temperature, the sweat rate, or the exercise heart rate across the menstrual phases in the analysis of all this combined data, which is actually quite strong evidence that we then have that there's not really a significant effect of the change in body temperature that we actually speculate, can cause, or, it may lead to different fluid intake or, electrolyte intakes. So we don't really have evidence for that, and because there does not seem to be a very, significant change in the body temperature. But we still have limited data that suggests that the observed increases in the internal temperature in the phase are maintained throughout and in post-exercise, but without an observed impact in sweat rate and mean skin temperature. So on the note of, adapting management or training to optimize performance, there's many unknowns that remain concerning the interest of periodization according to the different, the variations of hormonal levels during the menstrual cycle, and whether, we should encourage the use of oral contraceptives in high-level sportswomen. I think Marlena pointed out quite nicely as well, what the pros and the cons are, for example, of an intrauterine device versus an oral contraceptive. So more studies on female sports populations should be conducted in the future to better understand the effects of the hormonal status on training adaptation. Then there was another study in 2021, also quite recent, which looked at the effects of the menstrual cycle phase on an elite athlete's performance. And the important thing here is that there's different sports performance-related parameters that are affected during the menstrual cycle, especially in elite athletes, not running around, sorry. But the parameters themselves and the magnitude and the direction of the effects are still inconclusive. So we can't yet say, one thing is going up and the other one is going down. There's too much variation between individuals at this stage to make a good conclusion on, what is happening and what can we do to address that. So we need, again, much more research and evidence to monitor on-field performance, in order to enable any recommendation or training individualization in female elite athletes. Then also a very recent study that was on the menstrual cycle and specifically related to sport injuries. We know there's the hormone variations that appears to be related to an increased risk of injury, especially during the ovulation phase because of that effect on the ligaments. And I think the important thing there is to say, it's speculated. It can have an effect on laxity, neuromuscular control, and the strength because it oscillates throughout the cycle, we think, due to the fluctuation in hormonal levels. And these oscillations peak in the ovular phase and coincide then with the with that rise in the estrogen. So the problem is that women need to constantly adapt to this fluctuation in hormones, and that theoretically exposes them to a higher risk of injury. But again, same conclusion, the lack of scientific evidence on this topic is remarkable, and further research is needed to validate any of these hypotheses that we have. So we know what happens to the hormones, and we speculate, because the hormone has an effect on tendons, ligaments, or muscle mass or bone, that the athlete will necessarily be, prone to increased risk of injury or other injuries maybe. But another factor that we need to consider is sports injuries have a multifactorial etiology. So if we are embarking on future research, which is much needed at this stage, we should consider all of these aspects, and sports practices, and to try and get to the best possible conclusion and recommendations for our female athletes. So the take-home message is, if we look at the evidence at this stage regarding adaptation of training, nutrition, first of all, we have the variation, the hormonal levels that fluctuate during the whole cycle, which we think may expose women to high injury risk. So, and I want to emphasize the think, because we can't say yes, it does, or no, it doesn't. Because we have this lack of evidence to substantiate any of these hypotheses that we have at this stage, and therefore also any adaptation to training at this stage must really be considered carefully and not taken, as a rule or thumb, or, yes, this must be applied, because of this lack of, we don't really know yet what's going on, and also because of individualization. We see there can be a lot of variability between women as well. And then actually some of our theories have already been proven not to be true. For example, the change in body temperature, it might happen, but it's not experienced, in a sense of affecting the athlete regarding sweating and, significant changes. So I'm going back to that very first slide that I have, regarding where we are with the research. So what we did is actually we jumped to the third part where we are already implementing, advice and guidelines and recommendations, while we actually haven't yet even established the efficacy or the effectiveness of what we think, can help or might be happening. So I think we need to take back a step or two and start at the basis. Because we, as Marlena also pointed out, you can't compare women and their injury risk and what they are prone to with the research that has been mostly done on men up to this stage. So we really need to make an effort to address this gap that we have at the moment to look after our female athletes and performance as well. So here's just a list of a couple of references that you can go and read in detail. We didn't have time really to go into detail, into these studies, but you can go and read a bit more on them if you like. And then I hope we will be able to circulate some of these information. Nutrition is actually a whole topic on its own, because, Marlena also touched on that as well, where we can use certain supplements to try and help, alleviate some of the symptoms. And, if it comes to performance, then you can also have a look at what supplements can help the women. But, ironically, I saw this, I think it was actually just after I through this article that the journal, which is actually a very good journal, supposed to be, has actually been taken off the list, and its impact factor has been removed. So how reliable this article is, again, in the end, I can't really confirm, as the journal is now not on the list, which makes you question the things that they are publishing. So this is where we stand at this stage, regarding what we know, what's happening in the menstrual cycle, and what evidence we have. And, there's a big gap in between to take what we know at this stage and start implementing advice and recommendations. Okay, so what we're going to do now, I'm just going to have a look at the Q&A, Marlena. I think a lot of questions will be some that you'll probably more be able to answer than myself. So I hope we're going to watch the time and we're going to try to work through all of them. The first one, Marlena, I think I know you know quite a bit on this as well. So the question is, please could you touch slightly more on testosterone levels and the effect of the menstrual cycle, especially now with the studies into DSD, transgender athletes, and the banning of them in world athletics? Is it only affected at ovulation or throughout?
Yeah, I was thinking that was what would be something that someone would like to talk about. It's been in the news this week. I think it was the end of last week that the International Federation of Athletics, World Athletics, announced the ban. DSD is just for those differences in sex development. So that's usually athletes that has testes in their body and they look like females. So the external part is different from what they have internally. And with the testes in the bodies, it doesn't exactly produce the same amount of testosterone as it would in men, but they do have far higher levels of testosterone than in women. Now, just to clarify, testosterone actually doesn't affect the menstrual cycle at all. All that we've noticed is that there is a slight peak during the time of ovulation. So it doesn't impact the menstrual cycle. So let's just say that to one another. What the World Athletics has come up with is that these athletes who wants to perform, transgender women, they must now for 2 years, where it was usually just 1 year, 2 years, have low levels of testosterone proven in their bodies, and they've halved it to, usually it was 5 nanomoles per liter, and now they've halved it to 2.5. So that's quite drastic what they've done, but there is a working group around this, and the chairperson of that is a transgender person. So I really hope that they will find a way how to accommodate, our transgender athletes as well, and make competing fair. That's just my 2 cents on this, Corlia.
Thanks, Marlena. No, I think it's more than 2 cents worth that. Second question, in our limited resource setting in South Africa, outside of the private practice, what would we suggest in terms of contraception for athletes, since the Marina is not usually available?
Corlia, it is interesting to know that lately the Marina is becoming more available in state patients. That I know as a fact. So it is more available than 5 years ago. But a very good alternative to that is easily available in state is the Implanon, that you can insert into the bicep of, not the bicep, but just subcutaneously in the upper arm, and that only produces or releases testosterone. My tongue is tying. It releases progesterone into the system, so it in a way suppress the formation of the endometrial lining. So you do get a bit of amenorrhea, but the ovaries are not completely shut down, so they do continue to produce hormones. So that is a very good alternative, the Implanon. And usually it's a very simple procedure that a nurse, they are actually actually trained to do it, and you get a little bit of local here in the middle of your arm, in between the bicep and the tricep. There's a nice little area where one can insert it. You give them a little bit of a local anesthetic, and you slip it in, and that little the little stick can stay in for 3 years, and that is a very convenient form of contraception to use that only contains progesterone.
Okay, great. Thanks, Marlena. Okay, I just want to scroll down here. So the question is, sorry. May you please elaborate more on the best time to conceive? Does it mean that you will have a difficult pregnancy if you conceive after 25, as in the physical form, or does it mean that you, if you have a baby that is cognitively not well developed or healthy later on?
No. Yeah, I may be just a bit too passionate, but the thing is, I said at some point we were born as females with all our follicles on board. We never ever make new genetic material. So a little baby girl is born with all the potential to one day become a mother. When men, we know, on the other hand, they are Mr. Eveready. They produce sperm every 6 to 8 weeks. There's a new batch of sperm, you know. So the difference is that we have all our genetic material on board. So our genetic material in our ovaries, our follicles, are as old as we are. So the thinking is that it's more problematic in terms of the outcome of a pregnancy with Down syndrome and compromised babies is after 35. But the age of 25 is just, that's the perfect time, or the not the perfect time, but the best time to conceive easily, where you will not struggle to fall pregnant. So you are very fertile from around the age of 25 to 30. And it's always, we advise it, but life doesn't work like that. If women can, they should have their first baby at least before 30. But I mean, reality is just so much different, and this is quite a difficult message to convey to women that's young and studying and working on a career, or working on a sports career, participating in sport. But it's just good to be confronted with the reality that the best time to have your children is actually in your mid-20s going on to 30. And I know in the States there's actually insurance that people working at Google and all these Silicon Valley companies, they give that as a benefit to their patient, their workers, their employees, to have their eggs frozen so that they can have them in their best years. So there's also a little bit of inequality, I think, with regards to that. But it's not that you will have a abnormal or differently abled baby if you don't conceive at 25. It's more becoming a problem after 35, but it's more easier, and your eggs are young and in a good state to conceive. So it's more, you are more fertile around about that age. So if you want to freeze eggs, that's the good time in your 20s and not in your 30s or 32, or, you know, wake up too late. That's more what I meant.
Okay, thanks, Manya. Yeah, and I think the challenge is as well that, you know, unfortunately, that's also the time frame when many high-performance athletes are in their, you know, peak performance. So, yeah, to find a balance, and I also think that might be a reason sometimes why they tend to wait a bit, you know, for having babies. Yeah, so it is a decision and a balance thing.
I think we should get some sponsors to sponsor them, not just for a pair of good training shoes, but maybe, you know, sponsor a one-stop cycle to freeze the eggs. I think we need a whole new, you know, paradigm shift on this.
True, Marlena. Okay, next question is, do you have any advice for treating patients or athletes with premenstrual dysphoric disorder for everyday life, not just sport? It doesn't seem to be well documented or even acknowledged.
Oh, that's quite something to suffer, and I do see it. This premenstrual dysphoric disorder, and what I think, just a little bit of advice is that you can go to your doctor with is to in every week of your cycle, choose a day, and for 4 weeks in a row measure your estrogen levels, because it's the estrogen that varies so often and causes this PMS symptoms. It's sometimes instead of just going onto an oral contraceptive and an antidepressant, because that's the teaching at the moment, it is beneficial to see in which week of your cycle do you actually have high and low estrogen levels, and according to that, take supplements, or even take a form of estrogen that we use in postmenopausal women. If your estrogen is low, just for that 2 weeks or that week, apply a little bit of the topical estrogen on your forearm to support you. So there is strategies, and like the person actually said, there's not a lot of evidence once again in that field, but there is definitely things that can be done, and you should just go to someone that can really individualize your situation, by looking at levels throughout your cycle, not just throwing a blanket like a pill, the oral contraceptive pill, over it, because usually that doesn't fix the problem on its own.
Okay, thanks. The next question, Marlena, is how long is it generally safe for a professional female athlete that is pregnant to keep participating in elite competition in a normal pregnancy?
Yes, it's a tough one. Look, your body is used to competing. Your body is used to training. Your body will also always prioritize your baby. That placenta is like the best fighter for that human being. That it's the communication between your baby and the outside world, and your body, and taking everything from yourself. So I do think that it's important to individualize, and it depends on the pregnancy. If it's a low risk pregnancy, the answer is going to be you can compete until you just don't feel that you can do it anymore, and it depends on what you are doing. But I have had women that kept on exercising until the day of delivery. So it depends on so many things. If you're healthy, if the pregnancy is healthy, if there's nothing has been compromised with the baby, and what you are used to. And one must just, I just think, Corlia, when you were talking about, in postmenopausal women and tendons and injuries, we need to start promoting in all athletes, anyone doing sport, not just strength, but mobility and flexibility, and working on one's balance. And I think with a pregnant woman and a belly tipping you over, that is also important, that you work on balance exercises and support your training by doing things like Pilates and yoga. I just think that is something that we need to look into future studies as well, not just hormones. Like you said, it's so multifactorial, but So in short, for pregnant women, it's absolutely going to depend on the individual sitting in front of me how to make that kind of decision. But exercise in a pregnant woman is a fantastic thing, and I usually encourage them as far as possible to keep on exercising for as long as possible.
Yeah, I think also, what we also have, usually advise them to do is just don't start doing something that you haven't done before. So
yes,
now if you only run 10 kilometers, try and train for a marathon, because that's going to put the additional, load on the body, and that's where the problems are going to come.
Totally.
Okay, next question. I have a 16-year-old patient who is an elite swimmer with PCOS. So how will this impact on her performance and injury risk?
At entry risk. Corlia, what does it mean?
Injury risk. Yeah.
Okay, with PCOS, they don't ovulate very often. So that's the whole thing with PCOS, is that ovulation is a mystery. They are actually in the follicular stages if they're not on the pill or anything that regulates the hormones for a very long time. They have this high levels of this high levels of estrogen and actually lower levels of progesterone. So they are where we hypothesize actually in a very good space to participate. So I don't think it will have a negative impact on her performance.
Okay, thanks. Sorry, Marlena, I'm going through these questions because they keep popping up. Next question is, what's the suggestion, or what's the suggestion for postmenopausal for women who are at high risk of cancer, family history, positive for cancer, and effect on performance? So I think what's the suggestion we can make for postmenopausal women who are at high risk for cancer, family history of cancer, and how it can affect their performance?
It's a little bit difficult for me to answer this question. With a family history of breast cancer, one would be very careful in what kind of HRT you would prescribe. It's actually the only cancer that we would take into consideration when we consider prescribing HRT. The safest form of hormone replacement therapy is anything that you could put on your skin that bypasses the liver. So anything that you take in orally has to go to your liver. In the liver, it's activated into a metabolic active state, and then in the second time in the bloodstream, that's actually when it starts doing its job, what it's designed for. But that contact session that it has with the liver, that's where complications or where side effects comes in. So anything that we can put on the skin is actually just safer because it's already in a metabolized form and it's absorbed. But I mean, in a postmenopausal woman who doesn't want to take or cannot take HRT, I would suggest good supplementation, like calcium, at least 1,200 milligrams a day, vitamin D, definitely, and something like evening primrose oil is actually not a bad supplement to take in the menopause. And then there's nice natural remedies that one can take to decrease body core temperature if hot flushes and not sweats are an issue. Something derived from sage actually helps to lower the core body temperature. So I would think in that direction when I would advise someone who do not want to take any hormone replacement therapy and that is an athlete.
Okay, I think the next question is also interesting and something that I'm also thinking about. But so the question is, please could you give an indication of the risk of injury, in the 5 days in women not using contraception, such as hormonal, versus an attempted manipulation to alter that risk? Is it worth the trouble? I think I'm first going to give you a chance, and then I'll maybe just add to that as well.
So the 5 days of injury. Just rephrase it or say that question again.
I think is it worthwhile or is it worth the trouble to try and manipulate the estrogen levels? Like we said, like some studies have looked at where they want to try and get the positive effects of the estrogen while trying to eliminate the negative effects of estrogen. So is it worthwhile to try and manipulate the hormonal levels, to that extent? I almost want to say, will it really make a difference?
I don't think it's for me. It's not about is it worthwhile. We really don't know for sure. But the thing with hormones is that you cannot just easily manipulate it. Even it's the cycle is so complex that you cannot just take something for say 14 days. only and think it will have exactly the effect that you want it to have. So that's the difficult thing, that hormones are so tricky, and that there's such an interaction, and it takes 3 months to switch off your own ovaries, to for them to stop releasing their own endogenous estrogen, progesterone. So that's why we start the pill, and sometimes we feel it's not working for me, but you're not on it for long enough. So that's just, hormones is not a quick fix. You cannot just quickly intervene. Even if someone contact me and say, I'm going on the Orange River canoeing in a week's time, I want to prevent my period, it's actually too late. You need to start earlier to prevent that period. And sometimes you have to take a tablet 3 times a day to prevent that. So if you want to manipulate your ovulation and prolong in a way the follicular phase, you'll have to actually take drugs that suppresses the release of the FSH, and then you actually become menopausal. So it's really not that difficult, that easy to manipulate the cycle. So I don't think it's worth your while. Maybe that's a short answer.
Yeah, and the conclusion we made, I think we're jumping the gun with the conclusions we are making or trying to make, while we haven't really done the groundwork yet. As you pointed out, it's not that easy, and it's not just taking a pill and manipulating it and there you go. And what will the effect be if you can try and manipulate it? I think there's too much we don't know yet.
Yeah, we don't know what we don't know.
Exactly. That's the problem.
And this is a fascinating, for me, it was so fascinating reading all of these going to look for information. And I really realized how many questions we actually have to ask about female athletes, and they don't even have to be elite, just any woman performing. We need to ask more questions about the influence of our cycle. And I honestly wish and hope that there will be more research, even from South Africa, going forward in this field.
Okay, one last question, because we're running out of time, unfortunately. So regarding female athletes that experience high levels of lower back pain during the period, will exercise help alleviate any of these symptoms?
Usually backache, there could be 2 obvious reasons. One of them can be endometriosis, and the other one could be that you have a retroverted uterus. So 85% of women, the uterus is just below situated just below the bladder, and in 15% of cases the uterus is pointed towards the back, and so that could be the reason for backache, apart from injury or that. The thing with exercise is increases one's endorphins, and I think endorphins are fantastic natural painkillers. So exercise is actually good. Exercise and a hot water bottle is we should never underestimate that in terms of pain relief. Not the only options, but it is good. Painkillers, I actually want to say. So exercise is still a good idea if you have lower backache, as long as you protect your back and don't do anything that can lead to more injury, because the pain is usually not from a back injury, but it could be underlying as a problem as well.
Okay, thank you everyone. I think so we will have to stop there as we're running out of time. It was a great session, I think, and I can, just from the questions coming from the audience as well, the interest in this area, and I think we really need to put more of our resources into this, and and pay more attention to the female athlete and the intricate systems we have, and how and if it affect performance, and how we can support our female athletes. Thank you, Marlena, for giving up your time. I know you're also quite busy with your practice and teaching and everything, but it's always nice to listen to you, and you're such a great person. So thank you so much.
Thank you, Corlia. It's a privilege.
Pleasure.
Thank you so much, Corlia, and thank you so much, Marlena. That was a really fascinating talk, and you can see there were so many questions generated and all those discussions. Clearly, everyone loved it. This is just to advertise our upcoming webinar, which is going to be next week, Tuesday. So it's not a normal Wednesday slot. It's going to be Tuesday at 6:30. So please let us know or sign up. We'll be sending out the webinar link. And thanks again.